My name is Jim Aragona. I'm an orthopedic surgeon with IGEA Brain Spine.
Hi, I'm Dr. Adam Lipson. I'm one of the managing partners and neurosurgeons here at IGEA Brain Spine in New York and New Jersey.
Adam, from time to time our patients do need operative procedures on their neck. How do you decide what specific operation will be done for a patient?
So the main operative procedures we have available are going through the front of the neck and the anterior cervical, either fusion or disc replacement, or going through the back of the neck and doing a minimally invasive posterior decompression, where I decompress the nerve, called a foraminotomy. I can also do posterior fusions when indicated. The linchpin of what we've been doing for years has been cervical fusions, and they are very effective. They generally accomplish the goal of decompressing the nerves, removing that disc, that's the pain generator, and then providing some stability and restoration of the anatomy. What we've seen over time is that there's been an evolution towards new motion preservation devices, disc replacement devices that can accomplish that same function but restore motion. It's individualized to what patients prefer, what would be best in terms of their anatomy. I think that the data shows that fusion is still fairly equivalent to disc replacement, but that's an ongoing process. You've seen this across the spectrum of development of cervical spine procedures. What have you seen?
Yes, I have. Well, I've seen all the techniques that you mentioned, but they all seem to have the same common goal. The first, to take the pressure off the neurological structures, be it the spinal cord or the nerves, to relieve pain and symptomatology, and then to restabilize the spine by either fusion or disc replacement. So when those two goals are met, we have successful outcomes for the patient.
Right, and I think the major benefits that we see, there's a lot of soft benefits as far as preserving motion in the cervical spine. There's times it's really not appropriate, where really a fusion, say for an unstable spine, is much more appropriate than a disc replacement. But what we are seeing is that there's a certain number of fusions that develop this adjacent level disease. The outcomes between fusion and disc replacement are about equal, but what we see is about 25% risk with fusion that the level above or below a fusion is going to wear out and they may need some subsequent surgery. That risk is definitely lowered in disc replacements, but I think the literature is still evolving there. And I think regardless, it's really got to be individualized for the patient anatomy. We have a lot of experience. We've been doing this over a decade, and we're one of the higher volume disc replacement practices in the tri-state area. I don't know, any other thoughts about the surgical?
I think that it all comes down to having the patient make an informed choice about the procedure that we recommend.
Agreed. Thanks.